So Kevin's going to talk to us about what do clinicians really want from National Clinical Audit. Over to you. I hope. Is that what you're going to talk about?
Not quite.
Okay.
So I once did that before, changed the title. And, you know, when you get the feedback after, so you'll notice that I've changed the title again. So I'm going to beg your forgiveness for changing the title here. You know, when you get the feedback comes through afterwards, and mostly they say nice things about you, don't they? One person wrote a 2-page essay on how Dr. Stewart shouldn't be allowed to change the title. It was outrageous. So of course, what other people do is they take the title and then they just talk about something completely different that they wanted to talk about. So I hope you will forgive me for changing the title slightly. But I hope that what I'm going to say is relevant. Jenny's right. I have been lucky enough to do those things. I was lucky enough to be an IHI fellow in Boston a few years ago. Carol Peden, who is going to speak later on, is an excellent speaker, and we overlapped when we were in Boston at the Harvard School of Public Health. I was also a medical director in Winchester for 5 years. It seemed much longer, but my therapist says that it's all getting better now. And I'm a geriatrician, and I still do a bit of that in Winchester. So I hope this is interesting. I hope if I speak too quickly or I say something that you don't understand, then just butt in. If you feel really, really strongly about something I've said and you disagree with it, or I guess if you agree, you know, if you agree with it, stand up and applaud, and that'd be wonderful. If you disagree with it, then, or you want a question or something, then stick your hand up and we'll have an interactive discussion. I won't let you talk for too long if you're monopolising the floor, so don't worry about that. So there is good news here. Sorry, I always feel more comfortable with a glass in my hand, and I don't know what that's about. So there's good news in this piece. When I was in the States a few years ago, Obama, it seems like an awfully long time ago, because Obama was just introducing his healthcare reforms, and actually he signed the bill, you know, at some stage during the year that I was there, and he had all the folks up to the White House to shake their hands and stuff, like they do. And one of the things that struck me was the issues that they were talking about in a very, very different healthcare system, in a very, very different culture. The issues with healthcare were exactly the same. They were concerned about poor quality, and they were concerned about variability, and they were concerned about rising costs of healthcare. Given that they spend about twice what we spend on healthcare, you know, I was surprised that I was hearing those messages. And I've stuck in some more travel snaps here. The place on the left is Oman, where the college does some work. And we've still got an ongoing piece of work that we do with Oman. But when you go to Oman, which is a lovely place and they're lovely people, and they've got oil wells out in the desert pumping out this stuff that is worth a fortune, they're talking about the same things. The rising costs of healthcare, variability and poor quality. And it's a completely different culture, completely different expectations of the healthcare system, completely different setup of the system, but actually the same things. Poor quality, high cost and variability. The other two photographs, I know there's people from Wales in the room, and I apologise there's nothing from Wales, so that sort of narrows it down, doesn't it? Because we tend to, we hear a lot of focus about NHS England and commissioning and, you know, the purchase provider split, and within the UK we have 4 different healthcare systems. But you know what? In every healthcare system in the UK, we're talking about the same things, which are increasing costs, poor quality and variability. The photograph in the middle is obvious, isn't it? Can anybody see that at the back? That's Edinburgh Castle. Okay, where's this one here, this bottom right one? Oh, look, come on, focus. Put your glasses on, Jenny. Anybody know where this is? Oh, dear. Hopeless. Okay, so we don't have a photograph of Wales. We're in England. We've talked about Scotland. Work it out. Yeah. This is in Enniskillen in the west of Northern Ireland, and I've put that photograph there for 2 reasons: 1, to show you that it's a lovely place, and 2, to show you that the sun sometimes shines there. But they've just built a spanking big new hospital in Enniskillen, and I was there a while back, and you know what? They're talking about the same things in a completely different system that has got integrated health and social care, completely different setup to the NHS in England, facing the same problems. So don't let anybody tell you that the issues that we're about to talk about are all local issues. These are universal issues across healthcare, across all sorts of different systems. We do, of course, all have different individuals. That, you know, we can't just take stuff from one system and translate it to another. That's a nonsense. There are local things to do with local culture and local politics, and some of those are better and some of those are worse in different systems. In the smaller systems in the UK, people on the front line feel much closer to the minister, who's much more likely to be on the phone when there's patient waiting in A&E in wherever it is than maybe in the NHS in England. But there are specific local things to do with the population and what they expect. The bad news really is that nobody's cracked it. You've probably all seen the latest version of this scorecard, which I haven't put up. But this is from the Commonwealth Fund in New York, which is a think tank which does comparisons of health systems internationally. The most recent version, the reason I haven't put it up is it puts the NHS as #1 for 2012. You know, it doesn't really matter where you are on the thing. The principle is the scorecard is used to really illustrate different dimensions of quality in different health systems. And from their analysis, they purport to show that some systems are good in some aspects of quality, some are better in others. There is nowhere that has really cracked it that is universally good across the piece. And it sort of depends on where you place your emphasis. There's a big emphasis in the US and from US organisations, as you might expect, on cost. You know, their costs are nearly a bit more than twice as much as us, probably, and a good bit more than most European systems. So they have a big emphasis on cost and think that we get pretty good value healthcare for what we spend. We probably think something slightly different about that. So we've got the generic issues in the UK, and then I think we have some very specific local issues. We have a lower baseline spending than most OECD countries. Whatever way you slice that, we have a lower baseline spending of about 9-point-something% of GDP. We certainly have a higher efficiency expectation. You know, what the sort of efficiency gains that are being talked about, pretty unrealistically in my view, are much, you know, in terms of percentage, are much higher than would be expected of other systems in other parts of the world, and you start to wonder whether that's deliverable. But of course, our political leaders point to the fact that we had a period of very high growth in spending in the NHS between 1997 and 2007. It was about 5% a year or just less across the NHS. Didn't particularly feel like that at the time, but it felt better than it does right now. We have, of course, got the fallout from mid-staffs. And again, while this has been a specific issue in a specific organisation in NHS in England, these issues are, the same issues are recognised across lots of organisations, across all of our healthcare systems in the UK, and I suspect internationally as well. So there's two possible approaches to improve. Are you all with me? Can you see this from the back? Oh, good. I can't really see you. but oh, yes, I can see moving shapes. Jolly good. So you know, there are two possible approaches to improving quality, aren't there? And people tend to fall into one or other camp. Although quite often some people will tell you they're in the camp that we've all got to pull together, and then they turn out to be in the other one. So I've put he's not my headmaster, who was much more vicious looking than that. But you know, we can either have the top down or the bottom up, and there are strengths and weaknesses to both approaches. And we in the NHS have used a lot of top-down measures to improve quality traditionally. So I think I put on the little slide, I spent a bit of time at the Department of Health a few years ago. At the time we were talking about quality and safety programmes. Bruce Keogh and others at the top of the Department of Health were very keen on directives to try and improve quality. And one of Bruce's arguments, which was absolutely right, was we made a directive to reduce MRSA and C. diff from the centre, and we told people just to bloody well do it. And you know what? 3 or 4 years down the line, things are much better than they were. And he was absolutely right. I guess I felt I had the scars of that from being a medical director, being one of those people who was just told to bloody well do it. And I understood, and I saw the focus that went on to getting the numbers right and the reporting right. Maybe perhaps more focus on getting the numbers right and the reporting right than actually making things better on the ground in retrospect. But there is no doubt that on some occasions directives from on high will work. I think there are limitations to how much that will work, but there's no doubt that on some occasions that works. And of course, the recent fallout from Francis, there tends to be a knee-jerk reaction that goes to that approach, doesn't there? We've got a legally enforceable duty of candour. We have a more stringent CQC regime. We have more compliance measures. We have safety alerts coming out. There'll be national campaigns. I think there's a Prime Minister's Dementia Challenge going on. There's certainly the dementia screening sequence thing. There's VTE. There's lots and lots and lots. Safety thermometer, which I was involved in. There are lots and lots and lots of things coming out from the centre. That you could broadly say are top down. There's also the payment system thing, and we've used that quite successfully with some of our national audits, and I suspect other people have done that as well. The best practice tariff, which was associated with the National Hip Fracture Database, made a real difference when it was first introduced a number of years ago. And it focused on a condition which, you know, I'm a geriatrician. I said, you know, I never thought I would see the focus on the treatment of patients with hip fracture who were a neglected group until there was a payment attached to it. And we have subsequently got lots of payments attached through Sequence or through QOF, which is not completely a quality payment scheme for GPs, but is partly that, or non-payment for never events. So we've seen a lot of benefit from things that are attached to payments, but I suspect that story has probably run its course, and of course there are downsides to attaching payments to things as well. The other bit that I've put in here under top-down, when I was preparing these slides 3 months ago, or possibly last night, you know, the other thing that comes from the top is the culture. And I've put in here setting and modelling culture, which I think is really important. And given that we've had a lot of focus on culture from following the fallout from Francis, we can go one of two ways. We can either model a culture from the top, which is punitive, and you will do. And I don't just mean from NHS England or from the government departments. I mean from people like us. You know, people in professional bodies, people in colleges, people running national clinical audits. If the culture from people like us is facilitative and supportive and helpful, then that will get transmitted down. If the culture from people like us is just bloody well do this because we found it's a problem and we're going to tell the CQC on you, then you're going to struggle with that. Hi, Emma. You can take that seat there, that's mine. So the payment system is alligator territory. And there was a great review from the Nuffield Trust a couple of years ago of the use of payment systems in different healthcare systems. You don't need to write the references down. I can send anybody the slides that need them. Use of payment systems in different healthcare systems. To cut to the chase, we tend to use payment system manipulation in the UK, I've said, but I suspect in NHS England particularly, we've tended to use the payment systems more than most. All the systems have unintended consequences. So every time you introduce a sequence or say, we will lobby to have a sequence attached to our audit outcome or something else, there will be an unintended consequences of that. If that's something we want to take, that's fine. But just be aware there's going to be fallout. There's often been poor alignment of incentives. So what the acute organisation is incentivised for is something slightly different from what the GP is incentivised for, is something slightly different from what the community organisation is incentivised for. So we're not going to get a system that works in coordination. The Americans have done a lot of stuff on this, because anybody American in the room? I love the Americans. I think they're lovely people. But you know, one of the, and so that's good, isn't it? You know, do you know what I really like? When you used to stand up to do a talk, so you can do a talk. Hi, Carol. When you can do a talk at something like this. We're just talking about Americans. You can do it. I know you've got an enthusiasm for them. When you can do a talk at something like this, and you can go out in the UK and you can sit down and nobody would clap. But when you do this sort of thing in the States, they sort of clap when you stand up. And then they're rapturous when you sit down. It doesn't matter how good or bad you've been. And I don't care. It gives you a really good feeling. So welcome. What I was saying was using the payment system. So in the US, where the healthcare system is obviously very much more commercialized, there's a real there's a real kind of yearning to try and see if we can use the payment system to improve quality and to make it work. And there've been pretty disappointing results from a lot of studies that have looked at that. So we've actually rushed headlong into the payment system stuff without thinking through, and I think probably without taking the example from systems like the US where it's been tried, and used carefully it can work really well. Used carelessly, then it can backfire. And there was also a great piece from Tim Dornan and the BMJ on the 8th of March this year, if you want to have a little look at it, on the QAF system. He's done a good analysis across it. So using the payment system, I would be cautious about it. And I would be particularly cautious in your national clinical audit when you say, look, it's worked for hip fracture or it's worked for whatever, therefore it must work for something else. It doesn't necessarily follow. This is, if you don't take away anything else, take away this paper and go away and read it. Mary Dixon-Woods' paper in BMJ Quality and Safety last year, 9th of September, I think. You've probably all seen it anyway, but if you haven't, it's a really great description of the culture and behaviour in the NHS, and it's describing some of the top-down things we've been talking about. I've just taken this I've just lifted this completely from the abstract. Consistent achievement of high quality care challenged by unclear goals, overlapping priorities, the distracted attention, and compliance orientated bureaucratised, I think that's what it says, management. The institutional and regulatory environment was populated by multiple external bodies serving different but overlapping functions. Multiple external bodies serving different but overlapping functions. We could be one of those multiple external bodies, or we could be a number of those multiple external bodies. So let's be really careful about thinking about the top-down approach and what's the best way to use it. It definitely works, but we need to be cautious about its use. The other side of the coin is the bottom-up approach. And I'm sure Carol is going to talk about a bit more about some of this, the IHI model for improvement and other approaches. So there's a whole range of, there is no one right way to do things. There's a whole range of different approaches which are lifted from industry, of which the IHI model for improvement is one, Lean and Six Sigma. These are all related. They're lifted from manufacturing industry, and they're what big manufacturing organizations have learned over the years, going back to post-war Japan. And they work really well in the right circumstances. In some circumstances, they don't work at all. We'll talk about that later. There's professional initiatives, which is what we're all about most of the time. That's audit and accreditation and guidelines and protocols and confidential inquiries. It's things that we can develop energy and enthusiasm on the ground for professionals to do for professional reason and professional pride and develop their service. And those are really key, but they're not the only answer. I've put in here patient-directed as a sort of bottom-up, because public reporting of outcomes is here, and the market is getting a lot of attention recently as well. Public reporting of outcomes is, I know, pretty high on HQIP's agenda, and good luck with that, Jane. Sorry, we're going to come back to public reporting of outcomes. I've done this already. Successful QI projects tend to have a focus on data and measurement. And they tend to have a focus on understanding the process and improving reliability. So that's really getting down to the nitty-gritty of how we get where we get, how the patient gets to their CT scan, and how they then get whatever the juice is that you give them when they've got whatever it is, and then how they get to the stroke unit and how we organise the care in the stroke unit. And let's go down and dissect the process and work on each of those bits of the process that aren't functioning. So it's a really hands-on, frontline, on-the-ground approach. Understanding things like demand and capacity and flow, not just grafting onto what's happening there already. There's a real partnership with patients. Margaret is in the room somewhere. Margaret, we were talking yesterday about seeing it from the patient's viewpoint, weren't we, when you moved to us, when you're having your care in a certain centre, actually, if we take a patient-based design approach, then we realise that the real issue is the transport or the appointments too early in the day or whatever it is you said in the thing we were talking about yesterday. From the patient's perspective, the most good quality improvement approaches take it from the patient's perspective. Adaptation for local culture and context, we've touched on that already. Just because it works in Winchester doesn't mean it's going to work in Manchester, and so on and so forth. Engaging leadership and getting them behind us, and involving and engaging staff. And these approaches can work really well when they do those things. When they don't work, it's usually because they haven't done those things. They haven't really reached into frontline staff and clinicians. They haven't really thought about how we spread and sustain. And I think we're all pretty bad at thinking about how we spread and sustain. They haven't really aligned with wider policy and strategy drivers. I've cited here the Safer Patient Initiative evaluation, which was a big programme run by the Health Foundation a few years ago. The evaluation was published in the BMJ in February 2011, and lots of these things that we now know are common features of work that doesn't really deliver what we expect it will deliver was seen then. There wasn't really an alignment with the national context and the other things that were going on, and there wasn't really an adjustment on site for the local context. Anybody know who said this? In every other walk of life, choice and competition and diversity drive up quality standards. Who said that? Oh, somebody help me out. Carol. Do you know who? Come on. Oh dear, this is hard work. Rona, you've heard this before. You must be. Dear God. Were you asleep the last time? David Cameron said this. David Cameron said this when he was trying to get the health bill through. I bet you he wishes he hadn't got the health bill through. But anyway, David Cameron said this on Radio 4. You know, it's not true. For starters, it's not true in every other walk of life either. So Bill Clinton, when Hillary was governor of New York, and Bill was walking around downtown Manhattan somewhere and got crushing central chest pain, and went to the local emergency room and discovered that he needed bypass surgery. He had two options. The chart on the right is the surgical outcomes from all the cardiac surgeons in New York State, of whom I think there are 175. And it shows you all their outcomes in the same way that we have our outcomes. So Bill gets crushing central chest pain. His wife is the governor of New York. And who does he go for to get his bypass surgery? Sorry? Yeah, he went to number 137 on the list. And why did he go to number 137 on the list? Yeah, Hillary knew them from the country club. Well, in fact, he went to somebody else who was actually playing golf at the time. So obviously, so he went to somebody that his wife knew, not somebody who was in the first 10 on the list of outcomes. I got to say, my dad, a few years ago, I was away at the time. My dad got bad cardiac trouble all of a sudden out of the blue type stuff. Aortic valve fell apart and all those things, and he needed cardiac surgery in a hurry. And I phoned my brother. I think I was probably doing an assignment on this sort of thing at the time, public reporting. I phoned my brother and I said, "Who do we know?" He said, "I know this guy in Belfast who does, he does a good job. I've worked with him once." And a week later, I thought, "Oh my God, I haven't even looked up the guy's outcomes," and I Googled them. So that's patients do what we do, which is they choose on the basis of personal experience, recommendations of family and friends, and convenience and locality and those other things. They probably do this. We, the public, probably do this with other things as well, other sorts of services. If you think about how you would choose a lawyer or an accountant or something that you don't use very much, that would be different from how you choose your supermarket or your computer. So we probably all do this. So the concept that people will choose the best, people will gravitate towards the best quality providers, and they will gravitate away from the poor quality providers, just isn't true. Public reporting does lead to improvement. Public reporting, personally, I think public reporting is the right thing to do. We're spending taxpayers' money here. The taxpayers paying for the service, and the people paying for the service ought to know what it is we're doing. And if there's something we're doing that we're not very proud of, then we ought to be able to put it out there and say, look, we don't think this is going well. So I think it's the right thing to do. I just don't think it's going to have the impact on quality that it is purported to have. But it does tend to work to some extent because we compete with each other. If Basingstoke are doing better than us or Southampton are doing better than Portsmouth, then we will tend to try and work out what they're doing that's better than us and get better than them, because we're all competitive animals. Apparently there's 73 shopping days left until Christmas. Anybody know that? I used to be a real fan of Delia. Anybody got Delia's Christmas book? I think it's brilliant. I think it's brilliant. So Delia tells you what time to get up on Christmas Day, doesn't she? Set your alarm, get up, peel the spuds or the potatoes, do the sprouts, you know, all that sort of stuff. Do this, do this, do this, do this, do that, do that, do that. You know, wash the, set the, da-da-da-da-da-da. 12 minutes past 3, perfect turkey on the table, good to go. And for years and years and years, I did the Delia method for the Christmas lunch. And you know, I think probably it was a midlife crisis that I sort of, you know, thought, oh, hell with Delia. Jamie Oliver came along, and his was completely the opposite, wasn't it? Anybody get Jamie? I've got his book as well. You chuck it all in a thing, and you just you have a glass of wine, and you go back and have a look. You know, that's not going to do. And poke it around with a bit of thing and all that sort of stuff. And you know, sometime in the afternoon, your turkey will be ready, and it'll come out. And you know what? It was as good as Delia's. So all that. There was much less stress. And then a few years later, I was started drawn. I find a lot of men of my age say this sort of thing to Nigella's method, and I haven't lost my affection for Nigella, despite her troubles. You know, the truth is, there is no one perfect way. There is no one right way to do it. And it's the same as improving quality. There is no one right way to do it. The best approach... I'd be very, very wary of people who say, all we need to do is lots and lots and lots of PDSAs on this, and that's going to make it better. And I'd be very wary of people who say, all we need to do is get a best practice tariff or a sequence associative, and that's going to make it better. And I'd be very wary of people who say, all we need to do is get the CQC to inspect for this, or you know, the NHS England to make a directive on this, and that's going to make it better. All of those things at different stages might have some effect on the outcome. All will have a downside as well. But the best approach is probably a balance. The top-down tends to get you compliance. The bottom-up tends to get you commitment. You need both. And probably the best way is to get your bottom up with your commitment, and then get the environment set by the top down, so as the directives aren't standing in your way, but they're aligning with what you're trying to do. What's this all mean for us? How are we doing on time, Jenny? There doesn't seem to be a clock in this room.
No, I should be following in your stead, because you're always very good on this. Yeah, you've got about 2 minutes left.
2 minutes? What? Yeah, good.
Speak fast.
All right. Grand. Okay, so there are just a few more slides. So thinking about all that stuff, you know, how do we think that national clinical audits might fit into this scenario? And again, we see a lot of folks coming, and you know, you will all see, and H Group will see us all, of course, coming with clinical audits at different stages. To be honest, national clinical audits seem to work when they seek to influence at all those different levels, at national policy level and at regulatory and commissioning level and at local level. And focusing on just one aspect of that tends to give disappointing results. But they do adapt and they grow depending on their level of maturity, and I think this is probably something that we've missed. I've done some stuff in the south of Ireland where they're setting up some national audits. And there's one on dementia just about to go. There's been some stroke stuff. At the setup stage or at the early stage, it's a very different sort of environment, and there are probably different things that you're trying to do from the stage that you've got a really well-developed one. At the early stage, you're often trying to get the subject on the agenda. Sometimes this is confidential inquiry territory. You're trying to get the subject on the agenda, outline what the main things are, provide some data. The data don't have to be great and they don't have to be perfect. They just have to be some data for people to say, actually, there's an issue with such and such. Energized clinicians who will often feel they've been banging on about stuff for years and want to make it better. Interested clinical leaders, interested policymakers, interested patient group who say, you know, it's about time we focused on this group. So those things are great for early stages in the national clinical audit. But as audits mature, we can't just stand still, and we can't just say let's put it on the agenda and shout louder that it hasn't gotten any better. We have to develop our audits to focus, I think, probably much more on methodology and data, and I think we need to focus much more on the quality of the outputs. We need to produce outputs which are good enough to be used across the piece. We spend a lot of money and a lot of energy, and we take up a lot of people's time collecting data. We need to use the information that we generate for as many purposes as possible. And that means for clinicians, for sure, for frontline staff working on the ground to improve, but it also means for organisational leaders and policymakers. It means for commissioners and regulators, and it means for the press and the public and everybody else. We will gradually move from organisational through process and outcome measures, bearing in mind what I said earlier, which is if you don't understand the process, you're never going to make it better. So you need to understand the process and not lose that. And there are, you know, I think probably there's too much of a tendency for us at the centre to focus on let's collect some more data because that would be interesting. The burden on the frontline staff is crippling. And I think we need to really think about the burden. I think we need to think about aligning with other work and other measures. Where can we reduce the burden of data collection, align with existing? You know, there's stuff out there which is collected, there's data which are collected. They're not perfect, but they might be good enough for some purposes. There's stuff in national databases which is there. We need to think more about aligning with that. We need to think more about aligning across. I think this is great, because it gets people working in different areas, talking to each other and thinking about how we might align some of the work we're doing. I think we need to think beyond the mega database model. You know, it's the current information governance landscape is complicated, and it's just looking at the newspaper clips this morning, it doesn't look like it's going to get better anytime soon. So I think we need to think more cleverly than the mega database model. We need to think, how do we assess quality? I think we need to, in perhaps a different way, I think we need to think, how do we assess quality, particularly in primary care, which is something we've not been very good at. And I've put at the bottom reader-friendly presentations of outputs. You know, we produce outputs which are for clinicians, and we adapt those, and some of our work has done really well in changing that around in recent years to produce stuff which is more readable by people who aren't clinicians in that specialty. But I think we've got an awfully long way to go. And I think actually most clinicians, if they're truthful with you, if you produce a public-friendly version of the report, they'll read the public-friendly version of the report because they understand it more easily than what you produced for the clinician. This is me of a Friday night. They're very stylish Calvin Kleins, I can tell you. You know, this stuff is difficult. Are there any clinicians in the room who... this little book is called The ECG Made Easy. Does anybody remember buying this when you were a med student? Yeah. So this is a little tiny book. It's about 20 pages long or 30, and it's called The ECG Made Easy. And every chapter, there's a bit, you know, this first bit is on the P wave or whatever, and the next bit is on the QRS. And at the end of chapter 1, it's, you know, principles. Number 1, the ECG is easy to understand. Number 2, the P wave is caused by da-da-da. Chapter 2, number 1, the ECG is easy to understand. The only principle I learned from that bloody book was the ECG is difficult to understand. It took me years and years and years, and once I understood that it was difficult to understand, then I understood it, because I was looking for something that was easy. This stuff is not easy. You know, if somebody says there is an easy solution, all we need to do is X, Y, Z, then just walk away. This stuff is not easy, it's difficult. And you can't simplify something which is really complex. You can't reach for a simple solution. The top down is going to get you compliance, the bottom up is going to get you commitment. You're likely to need both, but think about the balance that you've got in that. I think what we do with clinical audit has been great. I think we've made a lot of change, and we've improved the quality of care for lots and lots of patients in lots of different ways, but I think we've got a long way to go. I'm sorry for over-speaking my time. I think there's questions later on, but I'll put up my acknowledgement slide and then you can all clap. Thank you. And thank you, John. The cheque is in the post.